Here's a comparative table between left to right and right to left shunts in congenital heart diseases. Feature: left to right shunt, right to left shunt. Definition: abnormal blood flow from the systemic to the pulmonary circulation. Abnormal blood flow from the pulmonary to the systemic circulation. Common causes: atrial septal defect, ASD, ventricular septal defect, VSD, patent ductus arterios, PDA, tetralogy of Fallot, transposition of the great arteries, TGA, tricuspid atresia, Eisenmenger syndrome, late complication of unrepaired left to right shunt, oxygenation, usually no significant cyanosis initially, may develop over time if Eisenmenger syndrome occurs. Cyanosis present early due to deoxygenated blood entering the systemic circulation. Clinical features: heart murmurs, signs of heart failure, e.g., dyspnea, fatigue, failure to thrive in children, cyanosis, blue skin discoloration, clubbing of fingers and toes, polycythemia, increased red blood cell count, complications, pulmonary hypertension, right heart failure, Eisenmenger syndrome, decreased oxygen delivery to tissues, risk of paradoxical emboli, brain abscess. Diagnostic findings: echocardiography shows increased pulmonary blood flow. Chest X-ray may show cardiomegaly and increased pulmonary vascular markings. Echocardiography shows right ventricular hypertrophy and possible overriding aorta in TOF. Chest X-ray may show a boot-shaped heart in TOF. Treatment: surgical or catheter-based closure of the defect is often curative. Management may involve palliative shunts, complete surgical repair, or heart-lung transplantation in advanced cases. Prognosis: good with timely intervention. Risk of developing Eisenmenger syndrome if untreated. Varies by specific condition. Generally more serious with potential for significant morbidity and mortality. This table highlights the primary differences between left to right and right to left shunts, which are pivotal in understanding the pathophysiology, clinical presentation, and management of these congenital heart conditions. Ventricular septal defect, VSD, summary for cardiologists. Description: VSD is an abnormal opening between the left and right ventricles, leading to left to right shunting of blood. Epidemiology: it is the most prevalent congenital heart defect observed in clinical practice. Etiology: associated with genetic conditions such as Down syndrome and maternal diabetes. Pathophysiology: predominantly occurs in the membranous portion of the septum. The defect facilitates left to right blood shunting, causing right ventricular, RV, and left ventricular, LV, volume overload, RV hypertrophy, pulmonary hypertension, and eventually LV hypertrophy to the increased workload. Clinical features: auscultation. A hallmark finding is a harsh holosystolic murmur, best heard at the left lower sternal border, often accentuated by maneuvers increasing LV afterload. Symptoms vary by defect size. Small VSDs might be asymptomatic, while larger ones can lead to heart failure symptoms, as pulmonary vascular resistance, PVR, normalizes postnatally, enhancing the shunting volume. Diagnostic findings: echocardiography, the primary diagnostic tool revealing defect location, size, and hemodynamic impact, including shunt volume and pulmonary pressures. Chest X-ray might show cardiomegaly and increased pulmonary vascular markings in significant shunts. ECG can demonstrate biventricular hypertrophy depending on the chronicity and size of the shunt. Cardiac MRI, useful for characterizing complex defects and assessing associated cardiac anomalies. Treatment, management strategy, tailored according to defect size, symptomatic status, and the presence of complications like pulmonary hypertension and heart failure. Medical management, diuretics, e.g. furosemide, to manage heart failure symptoms, ACE inhibitors, e.g. enalapril, for afterload reduction, and beta blockers, e.g. carvedilol, for symptomatic relief. Surgical intervention, indicated for symptomatic large VSDs, failure of spontaneous closure, or complications like significant pulmonary hypertension. Techniques include percutaneous device closure for suitable candidates or open surgical repair. Follow-up, regular monitoring for signs of heart failure, arrhythmias, aortic regurgitation, and pulmonary hypertension is crucial. Prognosis: small VSDs often close spontaneously with excellent long-term outcomes. Larger defects requiring intervention have a favorable prognosis with timely surgical or catheter-based repair, though lifelong monitoring for late complications is essential. Clinical case, ventricular septal defect, VSD. Patient information, age, 18 months, gender, female. Presenting complaint, parents report the child becomes easily fatigued and has difficulty feeding. History of present illness. The patient, an 18-month-old female, has been noted by her parents to have poor weight gain and episodes of rapid breathing during feeding since birth. Recently, she has been less active compared to peers and sweats excessively, especially during feeding. Medical history, born at term with no complications, no significant illnesses or hospital admissions to date. Up to date with vaccinations. Family history, non-contributory with no known family history of congenital heart diseases. Physical examination, general appearance, small for age, mildly tachypneic at rest, vital signs HR 130 BPM like RR40 min, BP 90 60 mm/Hg, SpO2 98% on room air. Cardiovascular exam, a prominent holosystolic murmur is noted at the left lower sternal border with no palpable thrill. Peripheral pulses are normal with no signs of congestive heart failure. Respiratory exam, clear lung fields bilaterally with no added sounds. Other exams, remainder of the examination is unremarkable. PRIDAC, diagnostic tests, chest x-ray, mild cardiomegaly with increased pulmonary vascular markings. Electrocardiogram ECG shows signs of left ventricular hypertrophy. Echocardiography reveals a moderate-sized membranous VSD with a significant left-to-right shunt and no pulmonary hypertension. Management. The patient was initially managed conservatively with close monitoring of her growth and development and heart failure management including diuretic therapy, furosemide, to reduce symptoms of fluid overload. Given the persistent symptoms and evidence of a significant shunt without spontaneous closure, surgical intervention was recommended. The patient underwent successful surgical closure of the VSD with no complications. Postoperative course. The patient showed marked improvement in activity level and feeding within weeks of surgery. Follow-up echocardiography confirmed the closure of the VSD and normalization of ventricular sizes. Heart failure medications were gradually tapered off under close supervision. Follow-up and long-term management. The patient will continue to have regular follow-ups with a pediatric cardiologist to monitor for any late complications, including arrhythmias or ventricular dysfunction, though her prognosis is excellent given the successful closure of the defect. Discussion points. Timing of intervention. The decision-making process for surgical versus conservative management in VSD, considering the size of the defect, shunt volume, and clinical symptoms. Surgical approach. The benefits and risks associated with surgical closure of VSD, including the timing and technique of the surgery. Long-term outlook. Discussion on the long-term prognosis post-VSD closure and the importance of ongoing cardiac evaluation in her developmental years. Summary of atrioventricular septal defect, AVSD, for cardiologists. Definition: atrioventricular septal defect, AVSD, a congenital cardiac anomaly involving defects in the atrioventricular septum, the atrial and ventricular septa, and abnormalities in the atrioventricular valves. Etiology: strongly linked with Down syndrome. Associations noted with maternal diabetes and obesity. Pathophysiology: complete AVSD. Features both atrial ASD and ventricular septal defects, VSD, leading to left-to-right shunting at both atrial and ventricular levels, causing pulmonary overcirculation, biventricular volume overload, pulmonary hypertension, and heart failure. Partial AVSD involves ASD with less significant AV valve abnormalities, typically resulting in less severe symptoms that might not manifest until adulthood. Abnormal AV valve morphology contributes to regurgitation and potential in utero heart failure. Clinical features. Complete AVSD presents early with signs of heart failure, including failure to thrive, tachypnea, and increased work of breathing. Partial AVSD may remain asymptomatic into adulthood with potential for arrhythmias and heart failure over time. Diagnostic findings. Antenatal echocardiography can detect AVSD early, often prompting further genetic screening for Down syndrome. Postnatal echocardiography, gold standard for diagnosis, delineating the anatomy, shunt volume, and AV valve function. ECG may show left axis deviation and signs of left ventricular hypertrophy, LVH. Chest X-ray, global cardiomegaly, and increased pulmonary vascular markings in complete AVSD, enlarged right heart structures in partial AVSD. Involves diuretic therapy, e.g. furosemide for volume overload, ACE inhibitors, e.g. enalapril for afterload reduction, and inotropic support, e.g. digoxin in cases of heart failure. Surgical management. Recommended to prevent or mitigate pulmonary hypertension and heart failure, involving patch closure of septal defects and reconstruction of the atrioventricular valves. Timing of surgery, ideally performed in infancy to avoid the development of pulmonary vascular disease, with the exact timing based on symptomatology and hemodynamic compromise. Follow-up and long-term care. Requires lifelong cardiac follow-up to monitor for residual defects, valve function, potential arrhythmias, and heart failure management. Periodic assessment with echocardiography and, if necessary, cardiac MRI for detailed structural and functional evaluation. Key points for cardiologists. Recognize the strong association between AVSD and Down syndrome, warranting a high index of suspicion in affected individuals. Understand the hemodynamic implications of both complete and partial AVSD forms to guide timely intervention and prevent complications. Appreciate the critical role of early surgical intervention in complete AVSD to prevent irreversible pulmonary vascular disease and optimize long-term outcomes. Clinical case, complete atrioventricular septal defect, AVSD, in an infant. Patient information. Age, 6 months, gender, female. Presenting complaint. Parents report poor feeding, rapid breathing, and failure to thrive. History of present illness. The infant has struggled with feeding since birth, often becoming tachypneic and sweaty during feeds. She has not gained weight adequately compared to peers and has been increasingly lethargic. Medical history. Born at term with no complications during delivery, diagnosed with Down syndrome shortly after birth. Family history. No known family history of congenital heart defects or genetic syndromes. Social history. First child to non-consanguineous parents. Home environment is supportive with no exposure to smoking or other known environmental hazards. Physical examination. General appearance, small for age, mild cyanosis, and signs of respiratory distress. Vital signs: HR 160 BPM, RR 60 min, SpO2 92% on room air, weight below the 3rd percentile for age. Cardiovascular exam. A loud, harsh holosystolic murmur best heard at the left lower sternal border. A diastolic murmur is also noted at the apex. A palpable thrill is present over the precordium. Respiratory exam. Tachypnea with subcostal retractions, but lung fields are clear to auscultation. Diagnostic tests. Chest X-ray shows cardiomegaly with increased pulmonary vascular markings. Electrocardiogram, ECG, demonstrates left axis deviation and biventricular hypertrophy. Echocardiography confirms a large complete AVSD with a significant left to right shunt, moderate to severe atrioventricular valve regurgitation, and mild pulmonary hypertension. Initial management. The infant was admitted to the Pediatric Cardiology unit for heart failure management, including diuretics, furosemide, to manage fluid overload, and oxygen supplementation to maintain SpO2 above 94%. Nutritional support was initiated to address failure to thrive with high-calorie formula feeds. Definitive management. Given the diagnosis and symptomatic heart failure, surgical repair of the AVSD was recommended. The surgery involved patch closure of the atrial and ventricular septal defects and reconstruction of the atrioventricular valves. The procedure was successful with no postoperative complications. Postoperative course. The infant showed marked improvement in feeding and activity levels post-surgery. Oxygen and diuretic therapy were gradually tapered off. Follow-up echocardiography showed reduced pulmonary artery pressures, no residual shunts, and improved atrioventricular valve function. Follow-up and long-term management. The infant will require ongoing follow-up with a pediatric cardiologist to monitor cardiac function, growth, and development. Additional support for Down syndrome, including early intervention services and developmental assessments, was arranged. Discussion points. The association between Down syndrome and AVSD, emphasizing the need for early cardiac evaluation in these patients. The importance of timely surgical intervention in complete AVSD to prevent irreversible pulmonary vascular disease and optimize long-term outcomes. The multidisciplinary approach to managing children with AVSD, involving cardiology, genetics, nutrition, and developmental services to address the comprehensive needs of the child. Summary of patent ductus arteriosus, PDA, for cardiologists. Description. Patent ductus arteriosus, PDA, a congenital heart defect characterized by the failure of the ductus arteriosus, a fetal blood vessel to close after birth, resulting in a persistent abnormal connection between the aorta and the pulmonary artery. Epidemiology. More common in females, 2:1 ratio, and premature infants, with a significant incidence in neonates with maternal rubella infection, alcohol consumption, or phenytoin use during pregnancy. Pathophysiology. The persistent patency postnatally leads to a left-to-right shunt, causing volume overload in the pulmonary circulation and right ventricular strain, potentially progressing to heart failure and pulmonary hypertension. Clinical features. Small PDA, often asymptomatic, possibly discovered incidentally. Large PDA may present with failure to thrive, symptoms of heart failure, bounding peripheral pulses, and a continuous machinery murmur best heard in the left infraclavicular region. Diagnostics. Echocardiography, confirmatory test revealing left atrial and ventricular dilatation, shunt volume, and pulmonary artery pressure. Color Doppler shows blood flow from the aorta into the pulmonary artery. ECG, normal in small PDAs. Large PDAs may show left axis deviation and LV. Chest X-ray. Features include prominent pulmonary artery, aortic knob, and increased pulmonary vascular markings. Treatment. Pharmacological closure in premature infants. Indomethacin or ibuprofen to inhibit prostaglandin synthesis, promoting closure. Transcatheter occlusion, preferred in older children and adults with symptomatic PDA or evidence of significant left-to-right shunt. Surgical ligation, indicated when transcatheter occlusion is not feasible or in the presence of complex anatomy. Specific management considerations. Premature infants requires a multidisciplinary approach. Pharmacological closure with indomethacin or ibuprofen is considered for symptomatic PDAs, particularly in infants with respiratory distress or requiring mechanical ventilation. Contraindications for closure include ductal-dependent congenital heart defects and pulmonary hypertension with right-to-left shunt. In such cases, maintaining PDA patency with prostaglandin E1 infusion might be life-saving until definitive treatment is performed. Complications. Untreated PDA can lead to heart failure, infective endocarditis, and is a common cause of pulmonary hypertension and Eisenmenger syndrome in later life stages. Key points for cardiologists. The management strategy for PDA varies based on patient characteristics, such as age, weight, and the presence of symptoms or complications. Timely intervention is crucial to prevent long-term complications, with a preference for minimally invasive techniques like transcatheter occlusion in suitable candidates. Long-term follow-up is essential for patients with a history of PDA, even after successful closure, to monitor for potential late complications. Clinical case, patent ductus arteriosus, PDA, in a premature infant. Patient information, age, 10 days old, gender, female, birth weight, 1,1200 grams, gestational age, 28 weeks. History of present illness. The patient, a premature female neonate born at 28 weeks gestation, has been in the neonatal intensive care unit NICU since birth due to respiratory distress syndrome. Over the past 2 days, the neonate has exhibited increased work of breathing and a decline in oxygen saturation despite optimal respiratory support. Medical history. The patient has been receiving mechanical ventilation since birth due to respiratory distress syndrome. There is a noted history of maternal alcohol consumption during pregnancy. Family history: non-contributory with no known genetic disorders or congenital heart defects in the family. Physical examination: general appearance. The neonate appears tachypneic with subcostal retractions and nasal flaring. Vital signs: HR 160 BPM, RR 70 min, SpO2 88% on 40% FiO2 via mechanical ventilation. Cardiovascular exam: bounding peripheral pulses and a wide pulse pressure noted. A continuous murmur best heard at the left upper sternal border is present. Respiratory exam: diffuse fine crackles bilaterally with decreased breath sounds in the bases. Diagnostic tests: chest X-ray reveals cardiomegaly with increased pulmonary vascular markings. Echocardiography confirms a moderate-sized PDA with significant left-to-right shunting, leading to volume overload in the pulmonary circulation. Management: given the neonate's prematurity and symptomatic PDA contributing to respiratory compromise, pharmacological closure was initiated with a course of intravenous ibuprofen, aiming to promote PDA closure. Respiratory support was optimized, including adjustments to ventilator settings to minimize lung injury and support gas exchange. Hospital course: the neonate showed a significant reduction in respiratory distress and improved oxygenation following the initiation of ibuprofen therapy. Repeat echocardiography 48 hours post-treatment showed a marked decrease in the size of the PDA with minimal residual shunting. Gradual weaning from mechanical ventilation was initiated as the neonate's respiratory status improved. Follow-up and long-term management: the patient will require close monitoring in the NICU with follow-up echocardiograms to assess for complete closure of the PDA or the need for further intervention. Long-term follow-up with a pediatric cardiologist is planned to monitor cardiac function and potential late complications. A comprehensive developmental assessment and follow-up will be crucial given the neonate's prematurity and NICU stay. Discussion points: pharmacological closure of PDA. The efficacy of ibuprofen in promoting PDA closure in preterm neonates and considerations for its use, including potential renal side effects and contraindications. Impact of PDA on respiratory management: the challenge of managing significant PDAs in neonates requiring respiratory support, and the interplay between PDA management and ventilator strategies. Long-term outcomes: the importance of multidisciplinary follow-up for preterm neonates with PDA, focusing on cardiac health, developmental milestones, and neurodevelopmental outcomes. Summary of atrial septal defect, ASD, for cardiologists. Description: atrial septal defect, ASD, a congenital heart defect characterized by an opening in the atrial septum, allowing blood to flow from the left to the right atrium, leading to volume overload of the right side of the heart. Epidemiology: ASD represents the third most common congenital heart defect with a higher prevalence in females. Etiology: associated with genetic conditions such as Down syndrome and Holt-Oram syndrome, fetal alcohol syndrome, and intrauterine infections. Pathophysiology: the defect results from impaired septal growth or excessive resorption, leading to various types of ASDs, with ostium secundum ASDs being the most common. The left to right shunting of blood increases oxygen saturation in the right atrium, right ventricle, and pulmonary artery, potentially leading to arrhythmias, pulmonary hypertension, and right-sided heart failure over time. Clinical features: small ASDs may be asymptomatic. Larger defects can lead to symptoms of heart failure, especially in older patients. Auscultation may reveal a systolic ejection murmur, a widely split and fixed S2, and a soft mid-diastolic murmur. Diagnostics: echocardiography, gold standard for diagnosis, revealing the size and location of the defect and assessing shunt volume and right heart enlargement. ECG may show right axis deviation, incomplete right bundle branch block, RBBB, and right atrial enlargement. Chest X-ray, indications of right atrial and ventricular enlargement and increased pulmonary vasculature. Treatment: medical management, rarely required, but diuretics, e.g. furosemide, may be used to manage symptoms of congestive heart failure. Surgical repair, indicated for patients with significant right ventricular enlargement, large shunts, symptoms of heart failure, or a history of paradoxical embolism. Options include transcatheter device closure and surgical patch closure. Specific management considerations. Indications for closure include evidence of right heart enlargement, significant shunting, or the presence of symptoms. Transcatheter closure with a device is preferred for secundum ASDs, while surgical repair may be necessary for other types. Patients with ASD are at risk for atrial arrhythmias, and anticoagulation may be considered in those with large shunts, prior embolic events, or atrial fibrillation. Complications. Potential complications include paradoxical embolism leading to stroke and progression to heart failure, particularly in untreated or late diagnosed cases. Key points for cardiologists. Early detection and intervention are crucial to prevent long-term complications associated with ASD. Regular follow-up with echocardiography is essential to monitor right heart size, pulmonary pressures, and shunt reversal. Comprehensive management includes addressing associated arrhythmias, heart failure, and stroke risk. Clinical case, atrial septal defect, ASD, in an adult patient. Patient information, age, 32 years, gender, female, presenting complaint, increasing shortness of breath on exertion and occasional palpitations. History of present illness. The patient reports experiencing shortness of breath with activities that did not previously cause her any issues, such as climbing stairs or brisk walking, over the past 6 months. She also describes occasional episodes of palpitations, especially at night, that resolve spontaneously. Medical history. No significant past medical or surgical history. No medications currently being taken. Family history. Non-contributory, with no known history of congenital heart disease or sudden cardiac death. Social history. Non-smoker. Occasional alcohol consumption. Works as a high school teacher. Physical examination. General appearance. Well appearing in no acute distress. Vital signs: HR 88 BPM, RR 16 min, BP 1 in 20 80 mm Hg, SpO2 98% on room air. Cardiovascular exam: regular rhythm with a widely split and fixed second heart sound, S2, and a grade 2-6 systolic ejection murmur at the second left intercostal space. No jugular venous distension or peripheral edema noted. Respiratory exam: clear to auscultation bilaterally, with no wheezes, rales, or raunchy. Diagnostic tests. Echocardiography reveals a 2 cm secundum atrial septal defect with left to right shunting, right atrial and ventricular enlargement, and mild pulmonary hypertension. No significant atrioventricular valve regurgitation noted. ECG shows incomplete right bundle branch block, RBBB, and right atrial enlargement. Chest X-ray demonstrates mild cardiomegaly with prominence of the right heart border and pulmonary artery. Management. Given the patient's symptoms and echocardiographic findings indicative of significant hemodynamic impact, referral to an interventional cardiologist was made for further evaluation for transcatheter ASD closure. The patient underwent successful transcatheter closure of the ASD using an Amplatzer septal occluder device without complications. Post-procedural course. The patient reported a marked improvement in exercise tolerance and resolution of palpitations at the 1-month follow-up visit. Post-closure echocardiography showed complete sealing of the ASD with normalization of right atrial and ventricular sizes and resolution of pulmonary hypertension. Follow-up and long-term management. The patient will continue to have annual cardiology follow-ups to monitor for any late complications, such as device erosion or residual shunts. She was counseled on the importance of endocarditis prophylaxis for the first 6 months following the procedure and advised to report any recurrence of symptoms. Discussion points. The decision-making process for the closure of secundum ASDs in adults, weighing the risks and benefits of intervention. The role of transcatheter versus surgical closure in adult patients with ASD, considering factors such as defect size, location, and associated cardiac anomalies. The importance of long-term follow-up after ASD closure to monitor for potential complications and ensure sustained symptom relief and quality of life improvement. Summary of transposition of the great arteries, TGA, for cardiologists. Overview. Transposition of the great arteries, TGA, it's a congenital heart defect characterized by the anatomical reversal of the main outflow tracts, where the aorta arises from the right ventricle, RV, and the pulmonary artery from the left ventricle, LV. Epidemiology. Represents about 20% of cyanotic congenital heart disease, CHD, cases with a prevalence of 2 to 4 per 10,000 live births. Etiology. The cause is often multifactorial, with associations noted in infants born to diabetic mothers and in approximately 1% of patients with DiGeorge syndrome. Pathophysiology. The improper spiraling of the aorticopulmonary septum leads to separation of the systemic and pulmonary circuits, necessitating an intracardiac or extracardiac shunt for viability. Clinical features. Presents with cyanosis not alleviated by oxygen, tachypnea, and a single loud S2 on auscultation. Murmurs are uncommon unless associated with other defects like VSD. Diagnostics. Echocardiography. Confirms the diagnosis by demonstrating the origins of the great arteries and associated defects. Chest X-ray. Egg on a string sign due to the narrow mediastinum and enlarged cardiac silhouette. ECG. Generally normal and isolated TGA. Pulse oximetry reveals decreased SpO2. Treatment, initial management, aimed at promoting mixing of circulations. Prostaglandin E1, PGE1 infusion is initiated to keep the ductus arteriosus open. Balloon atrial septostomy, BAS, performed if PGE1 alone is insufficient to alleviate hypoxemia, enhancing atrial level mixing. Definitive surgical repair, the arterial switch operation ASO, is the treatment of choice, performed within the first few weeks of life, involving switching the great arteries back to their correct positions and relocating the coronary arteries. Specific drugs and interventions. PGE1, alprostadil, used to maintain ductal patency postnatally, facilitating mixing of systemic and pulmonary blood. BS, a catheter-based intervention to create or enlarge an atrial septal defect, ASD, for improved mixing. ASO includes resection and reimplantation of the coronary arteries, which requires careful preoperative mapping, usually via echocardiography. SHAB prognosis, untreated, TGA has a high mortality rate within the first year of life. Post-surgical survival rates improve significantly, with long-term survival beyond 15 to 20 years at approximately 90%. SHASH key points for cardiologists. Early recognition and intervention are critical in managing TGA to ensure patient survival and minimize complications. A multidisciplinary approach, including neonatologists, pediatric cardiologists, and cardiothoracic surgeons, is essential for optimal management. Long-term follow-up is crucial for detecting late postoperative complications, such as arrhythmias, coronary artery problems, and ventricular dysfunction. Clinical case, transposition of the great arteries, TGA, in a newborn. Patient information, age, newborn, 3 days old. Gender, male. Presenting complaint, the newborn is noted to have persistent cyanosis shortly after birth, which does not improve with oxygen administration. History of present illness. The baby was born at term via spontaneous vaginal delivery without complications. Cyanosis was noted immediately after birth, with initial SpO2 measurements in the low 80s on room air. Despite oxygen therapy, there was no significant improvement in cyanosis or SpO2 levels. Medical and family history. The mother is a 28-year-old prima gravida with a history of well-controlled gestational diabetes. No family history of congenital heart diseases. Physical examination. General, marked cyanosis, mild tachypnea without significant respiratory distress. Vital signs: HR 145 BPM, RR 50 min, SpO2 85% on 100% oxygen, temperature 36.7 degrees Celsius, 98.1 degree Fahrenheit. Cardiovascular, single, loud second heart sound S2, no murmurs detected. Pulmonary, clear lung fields bilaterally, no adventitious sounds. Diagnostic tests, pulse oximetry, persistent desaturation, SpO2 80 to 85% despite 100% oxygen. Echocardiography reveals TGA with the aorta arising from the RV and the pulmonary artery from the LV. No VSD or left ventricular outflow tract obstruction, LVOTO, noted. Patent ductus arteriosus, PDA, allowing some mixing of blood. Chest X-ray shows a narrow superior mediastinum and a globular heart-shaped egg on a string sign. HAC management. Initial management. Prostaglandin E1 alprostadil infusion was initiated to maintain ductal patency, promoting mixing of oxygenated and deoxygenated blood. Interventional procedure. Balloon atrial septostomy was performed on day 2 of life to enhance atrial mixing, resulting in a slight improvement in SpO2 levels. Definitive surgery. The patient was scheduled for an arterial switch operation, ASO, within the first 2 weeks of life. The procedure was successfully completed with relocation of the coronary arteries and switching of the great arteries to their appropriate ventricles. Postoperative course. The baby showed significant improvement in oxygenation post-ASO, with SpO2 levels stabilizing in the mid-90s on room air. The postoperative echocardiogram confirmed successful correction of TGA and adequate coronary artery perfusion. The neonate was gradually weaned off respiratory support and monitored for any signs of heart failure or arrhythmias. Follow-up and long-term management. The patient was discharged with close outpatient cardiology follow-up appointments scheduled. The parents were educated on the signs of heart failure, the importance of endocarditis prophylaxis for the first 6 months post-surgery, and the need for lifelong cardiac follow-up due to potential late complications. Discussion points. The importance of early detection and the role of prostaglandin E1 in managing TGA to keep the ductus arteriosus open for blood mixing. The significance of timely surgical intervention, arterial switch operation, and its challenges, including the relocation of coronary arteries. Long-term considerations, including the potential need for reintervention, arrhythmia monitoring, and ensuring normal growth and development of the child. Summary of pulmonary valve stenosis for cardiologists. Description: pulmonary valve stenosis, PVS, a congenital heart defect characterized by the obstruction of blood flow from the right ventricle to the pulmonary artery, leading to pressure overload and right ventricular hypertrophy. Epidemiology: PVS accounts for approximately 10% of all congenital heart defects, CHDs, making it a relatively common condition in clinical practice. Pathophysiology: the obstruction at the pulmonary valve leads to increased resistance against right ventricular outflow during systole, resulting in right ventricular pressure overload and subsequent hypertrophy. Clinical features: the clinical presentation can range from asymptomatic in mild cases to signs of heart failure in severe stenosis. A hallmark finding is a systolic ejection murmur heard best at the second left intercostal space at the sternal border, accompanied by wide splitting of S2. Diagnostics: echocardiography, the cornerstone for diagnosis, providing detailed information about valve anatomy, the degree of stenosis, pressure gradients, and right ventricular function. Chest X-ray may reveal post-stenotic dilatation of the pulmonary artery and right ventricular enlargement in more severe cases. ECG shows evidence of right ventricular hypertrophy, particularly in moderate to severe stenosis. Treatment: prostaglandin E1 infusion, used in neonates with critical PVS to maintain patent ductus arteriosus, PDA, until definitive treatment is possible, facilitating pulmonary blood flow. Balloon valvuloplasty, the first-line treatment for symptomatic patients with moderate to severe PVS, offering effective relief of obstruction with low morbidity. Surgical commissurotomy, considered when balloon valvuloplasty is not feasible or unsuccessful, or in the presence of dysplastic pulmonary valve leaflets. Specific management considerations: asymptomatic patients with mild stenosis require regular follow-up with echocardiography to monitor the progression of the disease. Intervention is typically reserved for symptomatic patients or those with a peak gradient 50 mm Hg across the pulmonary valve or evidence of right ventricular dysfunction. Prognosis: the prognosis is excellent for patients who undergo successful relief of obstruction, with most leading a normal life with minimal risk of recurrence or long-term complications. Key points for cardiologists: early detection and accurate assessment of PVS severity are crucial for optimal management and timing of intervention. The choice between balloon valvuloplasty and surgical commissurotomy depends on anatomical details of the valve and associated cardiac anomalies. Lifelong cardiology follow-up is recommended to monitor for potential late complications such as pulmonary valve regurgitation or residual stenosis. Clinical case, pulmonary valve stenosis in a young adult. Patient information: age, 24 years, gender, male, presenting complaint, progressive exercise intolerance and occasional palpitations. History of present illness. The patient, a previously healthy 24-year-old male, reports a gradual decline in his ability to perform physical activities over the past year, including difficulty keeping up with his peers during recreational soccer. He also mentions episodes of palpitations, particularly after exertion, which resolve with rest. Medical history. No significant past medical history. The patient reports being told he had a heart murmur as a child but never underwent further evaluation. Family history. Non-contributory with no known history of congenital heart disease or sudden cardiac death. Social history. Non-smoker, social alcohol use, works as a software engineer. Physical examination, general appearance, well-nourished, well-developed male in no acute distress. Vital signs: HR72 BPM, RR16 min, BP 130 75 mmHg, SbO2 98% on room air. Cardiovascular exam, regular rhythm, a prominent systolic ejection murmur noted at the left upper sternal border, peaking in mid-systole and diminishing towards S2. No cyanosis or clubbing. Respiratory exam, clear to auscultation bilaterally, no wheezes, crackles, or raunchy. Diagnostic tests: echocardiography, revealed doming of the pulmonary valve in systole with a peak gradient of 60 mmHg across the pulmonary valve, consistent with moderate pulmonary stenosis. Right ventricular hypertrophy was present, but right ventricular function was preserved. ECG showed right ventricular hypertrophy with a rightward axis. Chest X-ray, normal heart size with no evidence of pulmonary vascular congestion. Management. Given the symptomatic nature of the stenosis and the echocardiographic findings, the patient was referred for cardiac catheterization and potential balloon valvuloplasty. The procedure was successfully performed with a significant reduction in the transvalvular gradient to 15 mmHg and no significant pulmonary regurgitation on post-procedure echocardiography. Post-procedural course. The patient reported a noticeable improvement in exercise tolerance and resolution of palpitations at a 1-month follow-up. Repeat echocardiography 6 months post-procedure confirmed stable gradient across the pulmonary valve and normal right ventricular size and function. Follow-up and long-term management. The patient will continue with annual follow-up visits to monitor pulmonary valve function and right ventricular size and pressures. He was counseled on the importance of regular cardiac evaluations and was advised to return if symptoms such as exercise intolerance or palpitations recurred. Discussion points. The importance of early detection and intervention in symptomatic pulmonary valve stenosis to prevent long-term complications such as right heart failure. The role of balloon valvuloplasty as a minimally invasive effective treatment option for selected patients with pulmonary valve stenosis. The need for lifelong surveillance in patients with congenital heart disease, even after successful intervention to monitor for late complications. Summary of coarctation of the aorta, COA for cardiologists. Overview. Coarctation of the aorta, COA, a congenital narrowing of the aorta typically located at the aortic isthmus near the ductus arteriosus insertion site. It results in differential blood pressure between the upper and lower extremities and may lead to significant cardiovascular complications. Epidemiology. COA accounts for approximately 10% of congenital heart defects with a higher incidence in males. Pathophysiology. The narrowing leads to increased pressure proximal to the coarctation, causing left ventricular hypertrophy and potential heart failure. Collateral circulation develops over time, evident as intercostal artery enlargement, rib notching on X-ray. Clinical features. Neonates may present with shock and multi-organ failure upon PDA closure if COA is severe. Older children, adults. hypertension in the upper extremities, weak or absent femoral pulses, brachial femoral delay, differential cyanosis, and exercise-induced claudication in the lower limbs. Diagnostics: blood pressure measurements, discrepancy in systolic blood pressure between the upper and lower extremities. ECG: right ventricular hypertrophy in neonates, left ventricular hypertrophy may develop in older children. Echocardiography: gold standard for identifying the site and severity of CoA and associated cardiac anomalies, e.g., bicuspid aortic valve, VSD. Chest X-ray, figure of 3 sign, cardiomegaly, and rib notching. Advanced imaging MRI-CT utilized for detailed anatomical assessment, especially in adults or complex cases. Treatment: neonates with critical CO, prostaglandin E1 infusion to maintain ductal patency and medical management of heart failure. Intervention: surgical correction, preferred in neonates and involves resection of the narrowed segment with end-to-end anastomosis or patch aortoplasty. Balloon angioplasty, an option, particularly in recorctation post-surgery. Stent placement, typically reserved for adolescents and adults. Specific drugs and interventions: prostaglandin E1, alprostadil, used to keep the ductus arteriosus open in critical CoA to ensure lower body perfusion until definitive treatment. Antihypertensives, beta blockers, e.g. Atena's atenolol, or ACE inhibitors, e.g. lisinopril, may be required to manage systemic hypertension resulting from CoA. Complications: long-term risks include persistent or recurrent hypertension, recoarctation, aortic aneurysm or dissection, and premature coronary artery disease. Key points for cardiologists: early detection and intervention are crucial to prevent long-term complications associated with CoA. Lifelong surveillance is essential for patients with CoA, even after successful intervention, to monitor for hypertension, recoarctation, and aortic integrity. A multidisciplinary approach, including genetic counseling for associated syndromes like Turner syndrome, enhances patient care and outcomes. Clinical case, coarctation of the aorta in a young adult. Patient information: age, 25 years, gender, male. Presenting complaint: newly diagnosed hypertension and intermittent claudication during exercise. History of present illness: the patient, a previously healthy 25-year-old male, presents to the clinic with a recent diagnosis of hypertension during a routine physical examination. He reports experiencing leg fatigue and discomfort when jogging, which resolves with rest. Medical history: no significant medical history. No prior cardiac evaluations. Family history: non-contributory with no known history of congenital heart disease or sudden cardiac events. Social history: non-smoker, occasional alcohol use, software developer by profession. Physical examination: general appearance: well-nourished male in no acute distress and vital signs: HR72 BPM, RR14 min, BP 150, 90 millimeter harangue in both arms, not obtainable in lower extremities. Cardiovascular exam: normal S1 and S2, systolic murmur heard best at the left back and scapular area, decreased femoral and pedal pulses. Respiratory exam: clear to auscultation bilaterally, no wheezes or crackles. Hair diagnostic tests: blood pressure measurement revealed a significant difference between the upper and lower extremities, with brachial pressure markedly higher than non-recordable femoral pressure. Echocardiography demonstrated a narrowing of the aorta just distal to the left subclavian artery with a peak gradient of 45 millimeter Hg. No bicuspid aortic valve or intracardiac shunts noted. Chest X-ray showed rib notching on the inferior borders of the 3rd to 8th ribs and a mild figure of 3 sign on the aorta. CT angiography confirmed the diagnosis of coarctation of the aorta with a 2 centimeter segment of narrowing and extensive collateral circulation. Management: given the patient's age, symptomatology, and the severity of the coarctation, he was referred for endovascular intervention. The patient underwent successful balloon angioplasty and stenting of the coarctation site, resulting in significant relief of the gradient and improvement in lower extremity blood flow. Post-procedural course: The patient's blood pressure normalized in both upper and lower extremities post-procedure, and he reported resolution of exercise-induced claudication. He was started on a beta blocker, atenolol for blood pressure control, and to reduce shear stress on the aorta and stent site. Follow-up and long-term management. The patient was advised to have regular follow-up appointments with echocardiography to monitor for stent integrity, potential recorktation, and aortic wall changes. He was counseled on the importance of maintaining a healthy lifestyle and adhering to a medication regimen to manage his blood pressure and reduce the risk of aortic complications. Discussion points. The importance of considering coarctation of the aorta in young adults with hypertension, especially with disparities in pulse and blood pressure between upper and lower extremities. The role of balloon angioplasty and stenting as a minimally invasive treatment option for adult coarctation of the aorta. The necessity of long-term surveillance for complications such as recorktation, aortic aneurysm, and hypertension, even after successful intervention.